Welcome to our webinar titled 2021 EHA and ASCO MDS Update. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible you may lose your internet connection during the program. If you lose your connection, you can still participate by using the call-in number in your reminder email. Today's presentation is being recorded and will be available on our website within 2 to 3 business days. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, type the question or comment in the small text box window in the lower part of your screen. When you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Our specialist today is Andrew Brunner, who is an associate professor of medicine at Harvard Medical School and an assistant in medicine at the Center for Leukemia at Massachusetts General Hospital. He earned his medical degree at Brown University School of Medicine, completed a residency at Massachusetts General Hospital, and fellowships at Brigham and Women's Hospital and Dana-Farber Cancer Institute. Dr. Brunner's clinical area of interest and research projects are focused towards understanding treatment patterns and patient outcomes in MDS, as well as other advanced hematological malignancies, and to develop new treatments for these patients. He is involved in clinical trials for all stages of MDS with an overall goal of tailoring treatment to improve outcomes for patients. With that said, it's my pleasure to welcome Dr. Brunner. Thank you for joining us today.
Thank you so much for having me. It's a real pleasure to join and to talk about some of the research that's going on in the field of MDS and to provide some updates from this summer. You know, I think that over the last 1 or 2 years in particular, there's been a groundswell of energy to try to understand and identify new therapies and new pathways of treating MDS. And it's made for a lot more excitement at some of the recent national and international meetings. And so I'm happy to share a few updates that have been presented, ranging from some basic science advances to reports of clinical trials and trials that are in ongoing progress. And I think the overwhelming sentiment that I have for the field is that there are quite a few people working on MDS, identifying new therapies, and that our current established mechanisms by which we treat MDS are likely to change, I hope, in the coming years. And so there's a number of abstracts that I'll be discussing today, and they will go over a variety of abstracts presented at ASCO as well as ASH. There are some overlaps, so I'll just note those and skip them, but hopefully it gives a good sense of the range of research that's ongoing. So ASCO, the American Society of Clinical Oncology, was a great meeting this year, right at the end of May, beginning of June, and a number of studies were presented that you may have some relevance to patients that we treat. One of them, which was presented both at ASCO and at EHA, was a phase 2 study of IDH2 inhibitor, enasidenib. Now, mutations in IDH1 and IDH2, these are genes that are involved in cell metabolism. And these mutations were discovered, and really treatment was developed in acute myeloid leukemia, or AML, where they might represent 20 to 25% of patients. However, we see them in MDS. They're not as common, maybe 5 to 10% of people to have an IDH1 or an IDH2 mutation. The pill enasidenib is a very targeted inhibitor of that mutated protein, and administering it, it's been approved in AML, but there are a number of people with MDS where it's of interest to know whether they are patients who will respond. It adds to our arsenal of now targeted therapies for patients with MDS. And so this study was a phase 2 study. It reported some outcomes for patients who have IDH2 mutation in their MDS samples. And so it looked at 2 different treatment strategies. One was to take patients who've never seen any prior chemotherapy. And so many of you may know that azacitidine or decitabine hypomethylating agents or DNA methyltransferase inhibitors, so-called, but either of these agents is generally the first treatment that most people with higher risk MDS will receive. There is a survival benefit to azacitidine compared to other standard of care options. But a challenge with it is that not everybody gets a response. And the rates of remission and general benefit can be less than we would want. And so there's a lot of interest in trying to identify combinations that improve on the chance of any one patient getting a response. And so there was an arm looking at patients who got enasidenib and azacitidine to see how they did, as well as a group of patients who had prior therapy and couldn't tolerate it or progressed, and then they received monotherapy. So they just took this enasidenib pill daily, and it looked at response rates and how well they did. And it's a reasonably sized study, 46 patients. It showed that about many of them would achieve a response. Interestingly, about the same number in each group, combination therapy and monotherapy achieved what we call complete remission. But we also saw a number of patients who had other benefits. And so in particular, if you combine the two for upfront patients, many patients would have blast reduction in their bone marrow. And so that's seen by this marrow CR metric. Some patients would also have hematologic improvement. So the overall response rate in the front line is much higher than we typically expect with azacitidine alone. If we look at patients who have progressed on azacitidine, these are also really encouraging numbers. And so, I think that this study really validates that the responses that we've seen in AML translate pretty similarly into MDS patients. And that many patients who are on these pills can have some degree of response. And so for the few patients with MDS that have an IDH2 mutation, and probably similar with IDH1 based on our AML experience, although we need that data as well, there seems to be a chance for responding. And so it's worth knowing if you have such mutations and talking to your physician about them. I think this is an important practice impacting finding. Another study looked at a drug that also is approved in AML and is being evaluated in MDS. Venetoclax is an inhibitor of a gene that helps regulate whether a cell should live or die. It regulates this process called apoptosis. When a cell has too much damage, such as when cells have a lot of mutations or cancerous, they should automatically know that they have damage and tell themselves to die through controlled cell death or apoptosis. But because of number of mutations and other dysfunction within the cell, most cells are resistant to apoptotic cell death. And so they survive, and that's part of what makes them cancer cells. Venetoclax helps tilt that balance more in favor of the cell dying through apoptosis. And when combined with azacitidine and AML, venetoclax and azacitidine seem to have a real survival benefit over azacitidine alone. It has been approved in the use upfront treatment of patients with AML. We are evaluating the role of venetoclax added to azacitidine in MDS. And one of the things that we're looking at is how can it safely be combined? One of the biggest challenges with MDS compared to AML is that people often have lower blood counts at the start. They have chronic low blood counts that can lead to chronic infectious and bleeding complications. And they're often older on average than AML patients and may have other medical comorbidities. So one of the first things that we know about azacitidine and venetoclax in MDS is that longer courses of venetoclax are harder to tolerate in MDS. So in general, most studies have been looking not at continuous dosing as is done in AML of 28 days per cycle, but instead decreasing the venetoclax to only about 14 days because there is a lot of cytopenias and some toxicity from it when you give it continuously. People get infections, they get bleeding problems. Often when patients are in a response on venetoclax and azacitidine, and this is true of AML as well, we find that there's a cumulative buildup of toxicity on the bone marrow. So we don't see leukemia cells, for instance, in the bone marrows, but we see, if anything, that the chemotherapy is suppressing the normal blood counts from improving. And so a lot of our efforts are trying to find a nice balance. And for people who are treated on azacitidine and venetoclax, I often find that with my patients, I'm trying to find that sweet spot where they are responding to therapy, but don't have too low blood counts and aren't running into complications. In this study, they looked at a few different strategies for how to manage such patients. And in particular, they were curious about patients, what happened when patients have prior MDS or AML. So this is an extension looking at the patients who were treated on the approval study for AML of venetoclax and azacitidine. We know that patients who had a prior MDS or that got their leukemia from therapy have historically done worse than patients who do not have that history. But it was not known whether those patients would have the same benefit from the combination. And so in this study, we see that there was a higher response rate in patients both with therapy-related disease, as well as patients who had a prior MDS or MPN. And so in therapy-related disease, the combined response was 19 out of 31 patients, or 61%, compared to only 1 out of 9 patients in the placebo arm. And in those patients who have a prior MDS or MPN, 39 out of 59 patients, or 66%, responded, compared to 7 out of 26, or 27%. So the benefits of azacitidine and venetoclax that were seen in AML did not seem to be limited based on whether you had prior MDS, which is important since many people with MDS will go on to develop AML. And we'll talk in the future about in a couple slides about how we dose patients with MDS on azacitidine and venetoclax if it's used in that setting. There was an interesting study looking at, actually, let me just go to that right now. So as I mentioned, the challenge often in translating that AML data into MDS patients is the toxicity associated with it. In this analysis, they looked at a trial that's ongoing, and it's exploring dosing of venetoclax combined with azacitidine in patients who have higher risk MDS. And it looked at 2 dose modification strategies. One of these dose modification strategies was to dose reduce either the azacitidine or venetoclax by 33% for azacitidine or 50% for venetoclax. And then it could be shortened further each cycle. In a second strategy, they looked at stepwise reduction. So first reducing the azacitidine and then reducing the duration of venetoclax per cycle. It suggests that at least for short-term outcomes, the responses were similar. So you could use either dose modification strategy. You still had a good chance of getting response, remission, or hematologic improvement. I think a question that remains is how much we need to worry about dose modifying our azacitidine dosing and its impact on survival. Again, azacitidine being the only thing that has shown in the upfront setting a survival benefit. If you change that dosing too much, how far do you stray from that benefit? So that's a further study that's needed on this, but at least different strategies that we're employing to try to reduce toxicity by dose modification seem to be similar in nature for short-term outcomes. An outcome that matters across the board for patients with MDS and is a hard outcome to capture, one that we're studying, is what's their quality of life during all of these treatments. I think that some of the challenges that quality of life can vary day to day, week to week. If you're on chemotherapy and you're at the low point of your cycle, your quality of life may be very different if it's captured at that time compared to when you have count recovery and you don't need transfusions and you're feeling well. This is a large collaborative data set, the Connect MDS registry. And it had several built-in quality of life metrics. And this is a first look, a preliminary look to try to understand how quality of life changes from initial diagnosis to a point later in about 6 months later. And it looked at patients according to a number of kind of baseline risk factors. So low risk versus high risk MDS, patients, are you on treatment, best supportive care, or on active chemotherapy, and also by transfusion burden. Do you have no transfusion needs, low transfusion burden, or high transfusion burden? And this kind of data can be challenging to fully interpret. One of the, I think, challenging parts here is that there wasn't a clear difference between baseline and 6-month quality of life scores. And you can kind of see that in the columns, the baseline columns. The values look very similar to the quality of life values at 6 months. There's 3 scores used here, the EQ5D, the FACT, 2 different FACT surveys. And so, for each of these, the baseline to month 6, not huge differences. I think one of the areas that we need to work on as a field is how do we capture more meaningful? Do we need more frequent scores? Do we need to do them at certain clinical time points rather than just at a period? What this did show, which is somewhat interesting and kind of emphasizes the need to design trials that address patient needs, is that first, high risk MDS had a lower quality of life. People who are on therapy also have a lower quality of life. So how can we, by the time you get on therapy, how can we improve upon quality of life during treatment? And then also, I think quality of life varied significantly according to your transfusion burden. So whether you had low or high transfusion burden, actually those 2 groups look pretty similar as far as quality of life, but both were had a poorer quality of life compared to patients who do not have transfusion needs. So kind of priming the need to develop studies that address transfusion dependence in addition to high-risk MDS. Some of the studies that were presented were looking a little bit more at how certain new drugs are being utilized in care. And so one of those studies was looking at a trial of a drug called pevonedistat. And the full data we are awaiting. But this was a study that looked at AML, CMML, and MDS. So a lot of different cancers with some similarities, but also some differences between them. And it looked at how can we choose the right dose of this drug. And I think that this is a little bit of a peek behind the scenes of how drug doses are chosen. In one way, we want to make sure that people have on-target effective drugs. And so often we're looking at pharmacokinetics or PK values to say, all right, are we getting enough drug into the system? Or are we looking at activation, so binding of a drug to its target? Is it doing what we think it's supposed to do in people? And many trials are designed to do that. I think this is interesting because it looks at, well, in addition to, are we getting drug in and is it hitting its target? Is there an optimal drug point that we have kind of minimal toxicity with maximal efficacy? Obviously, that's what we'd all like to develop in drug development, is a drug that hits the target, does what it's supposed to do, but doesn't cause you a lot of problems. So this looked at how the dose of this drug, pevonedistat, related to toxicity, so neutropenia, febrile neutropenia, or AEs. And so they found that they could really optimize the dose for their phase 3 study by incorporating toxicity events on a more granular level than is usually done. And hopefully this kind of approach, patient-centered approach, is something that we continue to use in modeling what best dose to use for patients. Next, I think that one of the areas that we are looking at in MDS is just how are we delivering drugs? So we can come up with a great therapy, but if nobody takes it, it may be kind of meaningless, because how do we get a benefit to patients with MDS? This is a nice real world evaluation of, when we start patients on the most commonly used drugs in MDS, azacitidine and decitabine, or I guess the standard upfront treatments. Interestingly, other studies have shown that we don't give enough people hypomethylating agents in the first place. But we know from clinical trials that the maximal effect of hypomethylating agents really, most people need up to 4 to 6 cycles of treatment to say whether or not they're going to be a response. And other studies from this group and others have shown that, well, if you look in the population, the US population, how many patients actually get 6 cycles of azacitidine? Very few. Many patients stop well before they get treatment through that degree of 3 or 4 cycles. So this study tried to understand, all right, we know that, a third of patients with MDS with excess blasts, so these are people who really, they would be indicated for hypomethylating agents, and they started on them, but only about a third of them discontinued, stopped getting their treatment before 4 cycles. So arguably before we would know whether they would have an effect. Why did they stop? Especially since a sixth of the patient, half of this group, stopped after just 1 cycle of treatment. And so it's trying to understand what are the barriers to providing this care. And it seems like the main barriers really are comorbidities, poor performance status, and aging. So older patients are less likely to go on and get multiple cycles. And so if that's the case, how do we, in clinic, actually address that? How do we make sure that if we think we've got a therapy and we think that you could tolerate it since we started it, how can we try to get you through treatment so that you'd actually see benefit? Because we know it's going to take 4 to 6 cycles of therapy for many patients to see full benefit. So I think this is more elucidating some of the challenges of translating treatments to all patients, which have as much of an impact as discovering a new therapy, really. Now, at many of these studies, many of these conferences, we start to see more of these trials in progress. I think they don't provide as much data on what is actively being done in the trial, but they do give a good sense of where is the field, what's happening, where are people, where are some new discoveries maybe going to come out. At ASCO, there were a few trials in progress, just worth highlighting. One of them is the study we were talking about earlier, looking at azacitidine and this drug that's been approved in AML, venetoclax. And it's now in a phase 3 randomized study. still enrolling, so we don't actually know the results. But it's trying to do a head-to-head comparison of patients who have higher risk MDS, so less than 20% blast, and looking at patients who aren't immediately eligible for transplant, and then trying to compare whether the remission rates are different between azacitidine and the combination azacitidine venetoclax, as well as whether there will be a survival benefit. And so we're all eagerly awaiting both of those endpoints. You know, from my perspective, I think both drugs that improve the chance of gain of remission and drugs that improve overall survival are needed. It'd be great if we had a combination that did both. Another trial in progress, a similar phase 3 study. So looking for a potentially practice-changing agent. This is a different drug, magrolimab. Now, magrolimab is an antibody. Antibody therapy. It targets a marker, a little antenna on cells called CD47. And what we know is that CD47, when it's expressed on cells, it seems to tell other cells to avoid it. It's a so-called "don't eat me" signal. We have cells in our body called macrophages, and their job, kind of like the Pac-Man cells of our body. They go around and they find diseased, older cells or cells that don't belong, and they eat them, kind of clean the system. In this magrolimab agent, what it does is it blocks that signal, and MDS cells seem to overly express that. This blocks that signal, and so kind of allows macrophages to eat the cancer cells. And that's the rationale for combining it with azacitidine. Previous studies have shown encouraging response rates in relatively small groups. So does that response that we're seeing in these earlier phase studies result in an overall survival benefit? And so they've moved into a 1-to-1 randomized study where people would either get magrolimab along with standard azacitidine, or a placebo injection along with standard azacitidine. And they would receive it. There's a ramp up because when you give magrolimab initially, it seems to chew up the red cells. It preferentially chews up older red cells. So as you get new red cells from your bone marrow, those are less affected, but there is a little ramp up to avoid that, and then patients continue on. So here's another study that could greatly change how we approach people both up front and in later stages of disease. And hopefully we'll have some results from it as well in the coming years. And then there was another study in progress really looking at lower risk disease. Now, in contrast to high risk disease, where survival benefit is really what we're often looking for long-term, and response rates, in lower risk disease, it remains that the biggest challenge for patients is transfusion needs, transfusion burden. And so one of the difficulties is people can live with their MDS for a long time. They're often put on agents once they become transfusion dependent anemia, agents to alleviate their amount of transfusion needs. But once you no longer respond to that therapy, it has been challenging to navigate what next agents are available. Now, we did in MDS have a recent approval a year and a half ago of luspatercept, and that has added to the repertoire of treatments for lower risk patients who are transfusion dependent. But we are still in need. Once you stop responding to that, since people are living years with their disease, how do we, what else is available to try to alleviate transfusion needs? And so one of those drugs that's under evaluation is an agent, imetelstat. It's a telomerase inhibitor, and it telomeres are on our cells, and they seem to preserve the integrity of the DNA. When you many cancers have an increase in telomerase, which is one of these agents that helps them survive. And earlier studies looking at imetelstat in MDS, as well as been evaluated also in MPNs, have shown that about a little over a third, almost 40% of patients will achieve transfusion independence on this agent. And so this is a double-blind placebo-controlled trial that's trying to see, is that rate of transfusion independence, does it translate into other patients with MDS, and compare it to placebo to see, is this another agent that we can add to our low-risk MDS repertoire? And then there were a few studies that were looking at kind of novel angles to MDS. I'll go over them now as well. So one of those studies was looking at, we often, when I see a patient with MDS in my clinic, I'm often asked, what can I do on my own? What can I do lifestyle to alter the natural course of MDS? I think it's a tricky question, and it's still something that we're trying to figure out. But one of those stronger associations has been with smoking. Cigarette smoke has benzene in it. We know that benzene can be genotoxic. Smokers have a higher risk of blood cancers relative to non-smokers. If you look at large populations, it's a small but increased risk. And so this is a kind of interesting study looking at the outcomes of a cohort of patients who had prior smoking history or not. They found that most of the smokers in the group were male. They were more frequently had higher risk MDS, not significant, probably too small of a group to tell. And they also saw more mutations in a gene called TP53, which can be a hard gene to treat in MDS. And that was also a little bit higher, not significant, but also probably may relate to the size of the group. And I think a big challenge was that smokers in this group had a much higher risk of death compared to non-smokers. And so I think both trying to understand how cigarette smoke impacts the development of MDS, and also, what can we do to try to modify risk? Smoking cessation may play a role in both. The last ASCO abstract, and then I'll move on to the next session of EHA abstracts, was looking at a novel drug. So eltanexor is a new compound. It is a selective inhibitor of nuclear export, or a SINE compound. And a lot of tumors rely on that pathway to maintain, to replicate and kind of maintain their survival and expansion. So this drug is looking at patients who have previously had hypomethylating therapy. And we talked earlier about IDH inhibitors for the minority of patients that have those mutations. For a lot of patients who have stopped responding to hypomethylating agents, it's a really challenging situation. We don't have a lot of good therapies. So I looked at 20 patients, and they found that there were a number of patients who had activity. Most of these patients being 7 of them having a marrow CR, so meaning they had an increase in their blast count and it reduced by at least half, below 5%. And so, I think that when we're exploring drugs early phase like this, seeing signals for activity, there were also 4 patients who developed hematologic improvement and became transfusion independent. And 2 of those 4 patients had all their blood counts improve. And so I think these are the kinds of signals that we're looking for as we're trying to identify new compounds. And so a next step for this kind of trial would be to see, all right, are these small signals that we're seeing, do they translate into a larger population or into a more selective group of patients? So I think that, kind of encouraging to see ongoing research in MDS and new compounds being explored. Those were the abstracts presented at ASCO. I'll try to now go quickly through those presented at the European Hematology Association annual meeting in 2021. Also a great meeting, a lot of hematology focus, and MDS has played an increasingly center stage role at those conferences as well. So some of these are a little bit more into the basic science of MDS and trying to understand what are some new targets that we can look at. One of those was looking at a novel compound in a gene called WEE1, as well as looking at compounds that are targeting another DNA damage response agent, which is PARP inhibitors. When you have damage to your DNA, you need certain proteins to help fix it. One of which, for instance, is PARP. WEE1 is also involved in DNA damage response. So if MDS cells have mutations that cause DNA damage, can we use our knowledge about DNA repair to inhibit that pathway and selectively kill MDS cells? So this was using AML cells, but it looked at how WEE1 is increasing expression. So we're having a DNA damage response. If you give MK-1775 to those cells, it causes cell death. So meaning those cells are dependent on WEE1. If you add in a different pathway of DNA damage repair inhibitor, talazoparib, which is used in ovarian cancer or breast cancer, BRCA mutated disease in particular, we saw synergistic effect. And that's kind of seen through the increase in a compound that shows cell death, gamma H2X, and more kind of priming for apoptosis, BCL2. So maybe a space where we have a few drugs, talazoparibs, and already in humans. How can we use our understanding of DNA damage repair to advance some new therapies? A similar pathway that's challenging in MDS, aside from DNA damage response, is that of looking at activating mutations, specifically RAS. RAS is a gene that's mutated in a lot of different types of cancers, but in MDS, RAS gene mutations or mutations that are in the RAS pathway that kind of turn on cells are often associated with progression, transformation to AML, higher risk disease, worse outcomes. And many great minds have tried to figure out how can we target RAS, how can we try to impact RAS signaling. And one such compound that was really got all the way to phase 3 studies and is still under investigation is a drug called rigosertib. It's RAS mimetic that tries to tackle this RAS problem at the horns. And this study was trying to look at sequencing. So if we take our old standby azacitidine and we add in rigosertib, which blocks that activating pathway in RAS, does that have more activity? And so it looked like rigosertib alone did have some activity, but it's most active when you do a sequencing of rigosertib and azacitidine, where they cycle and then they can die. And so this is the kind of data that might go forward to inform how we treat somebody in a trial. So, do we give a week of one drug and then another? Do we alternate therapy? Do we give them concurrently? And so this is the kind of study that would help inform that. There have been a number of studies recently trying to understand the pathogenesis of MDS. And in particular, we've clinically noted a lot of patients will have autoimmune complications associated with their MDS. So people can have joint pains, people can have systemic inflammation. It is fairly common, maybe a quarter of people. Recently, there's a relatively rare syndrome called VEXAS that was described, where people have mutations in a gene called UBA1, and it results in this autoinflammatory syndrome. And so this is just trying to understand, all right, well, how prevalent are these mutations in MDS? And this is one study that looked at 33 patients that had these inflammatory symptoms. So if we're going to find a UBA1 mutation, we're going to look in people who have inflammation and MDS. And of those, there were only about 3 patients who had UBA1. So even though that mutation may drive a number of people to have both inflammatory disease and MDS, there's probably other mechanisms at play. Some of that might be mutation based. We're also trying to understand, why do some cells survive? Why do MDS progenitors survive when patients who have healthy stem cells in their bone marrow, why are they being outnumbered by these MDS cells? And one of the guesses is that there's an alteration in the cells that support the bone marrow, mesenchymal stromal cells. And, that maybe it's not just the MDS cells, but that the environment in the bone marrow where cells grow up is inhospitable to healthy cells. And so this looked at differences between MDS, mesenchymal stromal cells, and healthy volunteers, and suggests that there is some difference where these malignant bone marrows support MDS cells actually, and dissuade healthy marrows, and kind of may give us a future therapy where we're actually trying to change the environment, change the bone marrow environment so that it biases more towards letting healthy cells survive. We talked a little bit about the phase 3 study of imetelstat, so that's ongoing enrollment, and it's trial in progress presented at ASCO. One of the posters here at EHA was trying to understand, all right, if we've got 37% of people who responded to imetelstat, are there any predictors of who responds? And so they took the group of patients, 38 patients, and they looked at, is there any pattern of mutations in the patients who got imetelstat and had a response compared to those who didn't respond? And so in looking at these groups, they found that really there's a lot of different subgroups, different ways you can cut data. It's a small group in general, but there didn't seem to be an obvious signal between one mutation group or another, which can be good or bad. In a lot of ways, I'd rather have a therapy that works for everybody. So they didn't really see obvious differences between splicing factor mutated cohorts, patients who had mostly epigenetic mutations, patients with kinase mutations, that really influence the differences between the responses that they saw. Maybe some slight trends, but in kinase receptor patients were, overall, these are those RAS patients. These are more we worry about them progressing. Maybe they were on the lower end in general, but the kind of data that we need to see in a larger group. There are still responders in that group, for instance. Some of the data that was presented at EHA really looked at new combinations that are less explored. One of these areas that we're interested in MDS is we know that there's immune dysregulation. We saw the study earlier about autoimmune disease in MDS. When we combine hypomethylating agent here, this is a hypomethylating agent called guadocytabine. When we combine it with immune therapy, this is a PD-1 inhibitor, atezolizumab, PD-L1 inhibitor, atezolizumab. What is the chance of getting a response? And in particular, again, looking at that high-risk group, people who've had prior azacitidine and no longer responding. So in this study, they combined those two agents and tried to see, how many people responded. Is this possibly something that we could add on or use if people stop responding to their frontline azacitidine? So it looked at the combination, saw a response rate of about a third of patients. 2 patients got a remission. 4 patients had a reduction in blasts, so marrow remission. There's 1 partial remission, and 3 patients had some benefit, hematologic improvement. And, I think these are also still early. Historically, the survival after people have no longer responded to hypomethylating agents is pretty limited, maybe about 6 months on average. And this study showed it was, maybe 12 to 15 months or longer. So possibly seeing some encouraging signal that could be explored further, the idea that we could use immunotherapy in this disease. We're trying to also understand not just who responds, but who doesn't respond. This is looking a little bit again at our lower risk disease. So a study of one of our erythropoietin stimulating agents, the most commonly used agent for anemia, would be something that targets or acts like EPO, which is our body's hormone that turns on red cell production. Darbepoetin alpha is one such agent, or several of them. And this is looking at, are there specific mutations that may predict response or not? We know that some things will predict response to erythroid stimulating agents or ESAs. We know that if you have a lot of transfusion needs already, you're less likely to have a great response. We know that if your EPO level is already really high, so already above 500 or even above 200, you're less likely to have a response. So there's a number of factors we already know, but we don't know much about what mutations predict response. So in this study, they sequenced a number of patients and they found that mutations in one gene, ASXL1, seem to have much worse chances of responding to darbepoetin alpha. So this is an association we would need to explore in the future, but something that can inform the chance of response. There were a few studies that were doubly presented. I won't go over those. So similar to kind of this idea that can we tailor your therapy the best? Can we also figure out what are other high-risk features of patients? And so one of the issues in MDS is iron overload. Often that can be measured in a number of ways. Transfusion saturation. Transferrin is a molecule that binds and is a metric of kind of iron saturation in the body. And so in patients who had MDS that had transfusion needs, they looked at, all right, how does transfusion saturation impact survival? And they found that transfusion saturation can be a metric, especially if it's extremely high, above 80%. It can suggest poor survival. So in this study, patients who had greater than 80% transferrin saturation had pretty poor overall outcomes. And these were mostly very low, and intermediate patients. So people who are really red cell transfusions are their main source of need. And so it may suggest a group that we need to identify new research studies for specifically. Another study that was presented at ASCO as well. There were a few, there was a study in progress looking at a drug that's been improved, luspatercept, comparing it to epoetin alpha in the front line. So, we know that once you've progressed, luspatercept is an option for patients who have lower risk MDS. This is a trial that's in progress trying to say, all right, does the sequence matter? Should we be given luspatercept first and then doing ESA? How should we be ordering our drugs? And I think these kinds of studies are important because if you're going to live with your disease for a long time, it is important to know what sequence is correct. Obviously, many of the studies we've talked about couldn't be done without a lot of support, not just on the clinical side, but people getting to clinic, caregivers taking care of patients and family members and friends with MDS. So this study looked at, how does having MDS impact not just the patient, but also those who are taking care of them. And I think it's an underestimated group burden that really showed a high impact of the diagnosis, not just on the patients who have MDS who are coming into clinic, getting transfusions, spending long periods in infusion chairs or being hospitalized for infections, but also the family and friends and all those who provide care really have a big impact. And so, is there something that we can do to alleviate that as we try to advance MDS care? Some of the last studies here go into these ideas about what other targets can we look at in MDS. So we've talked a lot about inflammation in this last few studies. There are increasing interest in maybe targeting inflammation, dysregulated inflammation in particular, as a way to target and treat MDS. And so This looks in lower risk MDS and sees a number of biomarkers, IL-1 beta, having mutation in SF3B1, having del5Q, trying to identify, are there certain patients for whom anti-inflammatory based therapies might be relevant, and can we, now that we have a much larger repertoire than we had 5, 10, 15 years ago for anti-inflammatory targeted therapies, are there specific groups that we should look at for new therapeutic intervention? There's 2 last studies. One of them is looking at a drug that's now into phase 3 study. So this gets a little bit of overlap on both the dysregulated inflammation in MDS, as well as, are there new targets of the MDS progenitors that we can start exploiting? So this looks at a drug called sabatolimab. TIM3 is the target of this antibody. TIM3 is involved both in T cell exhaustion, so your immune system becoming exhausted, as well as in stem cell renewal. And this is looking at combining sabatolimab with azacitidine. And so this is the phase 1 data showing, reasonable response rates in fairly high risk patients. And those responses, when they happen, are pretty durable. So most patients staying in response by 6 months of therapy. So this is now being studied in a phase 3 trial, and hopefully we'll have a better sense of what impact it has and whether it can also change the field. It'd be nice if we all of a sudden have 3 novel agents in MDS, where we, especially in high-risk MDS, where we haven't had any change for about 15 years. The last study is with a related disease, CMML, chronic myelomonocytic leukemia. In many ways it gets lumped in with MDS, but it has a lot of different features and different behavior. And I think that this gets to that. So this is looking at the European registry for patients who underwent transplant. And it compares CMML patients who have often been lumped in with MDS in clinical trials compared to MDS after transplant. And it shows that, the CMML patients really do worse, and it's almost all due to relapse. So there's no real difference in toxicity from the transplant between the 2 groups, but compared to MDS patients, CMML patients are a higher chance of relapse. And so maybe we need to think of them differently. Maybe we should have more CMML specific trials and not just lump them into MDS as they have historically been. So with that, I hope you enjoyed run through a lot of research happening in MDS. That it's an exciting time in the field. And I hope that in the next couple years, we're talking about how to use all these new agents that we have. But I think we'll still have challenges ahead that we'll need to work on together. So happy to take any questions, and thanks for joining today.
Thank you so much, Dr. Brunner, for the wonderful presentation. We have a few questions. The first one is there a test, perhaps bone marrow biopsy collection, to measure or evaluate the mesenchymal stromal cells?
Yeah, it's a great question. Not in clinical practice right now. It's still really a study that's in kind of the preclinical research space. I think that one of the hopes would be that either we could learn about, can we donate mesenchymal stem cells just like we do bone marrow, or can we somehow target them differently? But I think it's still a little early for understanding patient to patient how those exist.
Thank you. We have a question that was 2 parts. Can you talk about the importance of MDS patients seeing an MDS expert to help with their care? What are the benefits, and why is that so important to make sure that your family member is seeing an MDS expert, not a general physician?
Sure. Yeah. I view many of us who are academic in this space are at larger referral centers. I view my role as a collaborative role. The reality is there's a lot of research going on in MDS. We have a lot more tools than we did, either borrowed from AML care, or, we are much better at providing therapy that are therapies that can be given to, for instance, older patients or patients with comorbidities than we used to be able to. For instance, here at MGH, we often are considering transplant for patients even well into their 70s, if they're otherwise fairly robust. And we know that transplant is the one curative therapy for MDS. Similarly, our ability to do mutation testing or to identify new targeted therapies, it's really an asset that is not necessarily available or accessible, I guess, at every community site. And so I think that it's helpful, especially at junctures that are important, to meet with an expert, like at diagnosis, anytime transfusion needs or blood counts change or blasts change. And I think that, discussing what makes the most sense as far as therapy at those junctures can be really valuable. But it's a collaborative effort. It takes a village, so to speak, to take care of everybody.
Thank you. And our last question we have is there a difference between current and past smokers in terms of response to treatment? If so, how many years difference would be significant for survival?
It's a good question. We don't know yet those kind of cutoffs. The study that I showed was relatively small, only 150 roughly patients. We would need larger pools of patients to be able to discriminate, cutoffs. I quit 5 years ago, 10 years ago, 15 years ago for MDS. If you look at other effects of smoking, for instance, lung cancer risk, we know that the longer duration since smoking to your diagnosis, the better, and that after, that risk decreases with 5, 10, 15 years. So my guess would be that the further out you are from smoking, the association decreases, especially because it would indicate that even if you had some injury to the bone marrow from benzene in cigarettes or whatever in cigarettes, you're further out from that. So that lag time would be probably more likely beneficial. So probably reduced, but from the study that was presented, we don't know. I'm just hypothesizing.
One more quick question, Dr. Brunner. Is cannabis use known to have a positive or a negative impact on MDS?
Yeah, it's a good question. None that we know of. The biggest risk with cannabis use in MDS is really it's an organic material. It can have fungus and mold in it, and inhaling that. The biggest problem I run into is people who have fungal lung infections. The legal status of cannabis varies, obviously. Here in Massachusetts, it is, it can be bought recreationally. I tell my patients to avoid, if they so use it, to avoid inhalation, so no vaping or inhaled cannabis, and to just use edible forms, because really it's the lung issues that cause such the biggest problems for my patients with MDS or other blood cancers.
Thank you so much, Dr. Brunner, for sharing your time and your expertise with all of us today. And if you'd like to watch the session again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline 800-747-2820 extension 2, or you can submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our session. Thanks again, Dr. Brunner. Have a great day.
Yeah, thank you very much.
Bye-bye.